Good morning, everybody. It's a great pleasure to be here to talk about TTP and the brain. But before I start, I'd like to start with a disclosure. I'm not a neurologist, so I obviously do not know as much about the brain as a neurologist does. What I have had the opportunity to do is follow a large number of patients with TTP and talk with them and observe what seems to happen with TTP and the brain. I'm a hematologist at Johns Hopkins Hospital, and this is one of my interests. Next, Claire. So today what I'm going to talk about is really three things. I'm going to start with what happens to the brain in acute TTP, where are we starting from? We'll go on to the brain when TTP is in remission and some of the long-term outcomes that may be seen in patients that have recovered from TTP. And finally, I'm going to talk about some future directions and research, essentially where do we go from here? Claire, next. So before I dive into this, I'd like to acknowledge that the TTP community has come a really long way. Dr. Marshall Mazepa talked about some of this, but TTP was first recognized in the early 1920s, where Dr. Moskowitz reported the case of a young girl who had low platelets, this anemia, and really severe neurological impairment who unfortunately did not survive. And the outcomes of acute TTP were not very good until the early 1990s when plasma exchange was established as a standard of care. And then mortality goes from almost everybody dies from acute TTP to the majority of patients are going to survive. And fortunately, mortality is less than 10% and continues to go down. This is huge. In the 1990s and 2000s, we got more of an understanding about how TTP happens and the mechanisms underlying it, and more treatments such as rituximab and caplacizumab to reduce the problems associated with acute TTP, whether it's during the first episode or whether it's preventing relapse, as you talked about in the last hour. And around this time, so the 2000s and 2010 onwards, because we are fortunate enough that many of our patients will do reasonably well, we've had the opportunity to focus on long-term outcomes, because that's our next goal, is to make sure that everyone lives their life to their maximum potential with as few problems as possible. Slide. So let's start with the brain and acute TTP. Slide. So when we talk about acute TTP, what does this look like? So common symptoms that you may have had when you've had TTP or you may have heard of are things like low platelets or thrombocytopenia and the anemia. And anemia means low blood counts, but when a hematologist looks at your blood under the microscope, it really looks like shredded blood cells or schistocytes. Other things that are frequently seen are fever and then impairment of different organs, whether it's the brain or kidneys. When you put these together, this used to be called the classic pentad of TTP, like these 5 findings were classic for TTP. What we know now is that this pentad is actually quite rare, and the majority of patients do not present with it. Less than 5% have all 5 findings. Things that are commonly present are the blood findings, such as the low platelets and low blood counts. And the second thing is neurologic symptoms or symptoms pertaining to the brain are very common. The brain seems especially susceptible to TTP. Slide. So in an acute TTP episode, when we look at hundreds of patients that have one, over 60% will have some sort of neurologic symptom at presentation. Now, this can be very variable. It can range from a headache or transient numbness or weakness that can actually come and go and be fairly mild, all the way to really severe forms such as being really confused. Some people unfortunately have seizures, strokes, and there are people that become unconscious or obtunded or have a coma. And not everybody presents the same way. There's a wide spectrum in how patients present. And if we look hard enough, neurologic symptoms are present in the majority of patients. Next. So the next question is, why do these symptoms occur during acute TTP? Next. And that speaks to the mechanism of the disease itself. I won't spend too much time on it, but I'm just going to walk through some of the really important points. So here you see the endothelium, which is the lining of the blood vessel. This clotting factor, called Willebrand factor, is seen as these long blue strings. And ADAMTS13, the enzyme that we've talked about so much, its job is to snip these long threads of clotting factor into smaller bits that can circulate in the blood without causing trouble. Next. What happens in TTP is that either you're born without this enzyme because of a mutation as in congenital TTP, or your immune system has decided to make an antibody against this enzyme. So now you don't have ADAMTS13 or this little scissor. And these clotting factor molecules, the ultra-large von Willebrand factor, does not get snipped into smaller fragments. And now you've got these long circulating threads of von Willebrand factor that are super sticky for platelets. And platelets do what they do best, they come and stick to them. So they form these aggregates or clumps. Next. These clumps go and form tiny clots in the blood vessel like you see here, and that's what leads to the problem. So what you see is as the red blood cells pass through these clumps, they get shredded by these fibers of clots. And you see these cells that look like little helmets here. They're called schistocytes, and they're quite characteristic of TTP. But more importantly, now these blood clots are blocking the blood supply to critical organs, leading to ischemia or a loss of blood supply. And that's what leads to the signs and symptoms of the disease. So that's why people are getting things like weakness, numbness, headaches, and confusion, because parts of the brain are not getting enough oxygen. Next. So neuroimaging means looking at the brain in different ways. So what does that look like in acute TTP? Common ways of looking at the brain are either to do a CAT scan or an MRI scan. And frequently during acute TTP, you may not see anything on standard imaging such as CAT scans. In patients that we do see some acute findings, things that are very common are evidence of microvascular injury, which means evidence of small blood clots, or some swelling and edema, particularly of the back part of the brain, the back of your head. And it's something called posterior reversible encephalopathy or PRES, and that's the most common finding. Important word here is reversible. Things do get better. Less commonly in patients who presented, for example, unfortunately with a large stroke during TTP, you might see evidence of that on the imaging. Next. So this is a picture of what the brain might look like in TTP. On the left-hand side, you see these little arrows towards the bottom. That's the back part of the brain. And these are what we call hyperintensities because they're bright. And these show some swelling in parts of the brain in the back. Now that doesn't look good to me. But the same patient at 12 weeks after recovery from TTP, things have normalized. It's gone away. So very critical. These findings, particularly the common ones, tend to resolve with recovery. They don't seem to impact how you're going to do with acute TTP. And most certainly, we should not hold up treatment just to get pictures of the brain. Right? What we don't know fully is whether these findings in the beginning of the diagnosis have an impact on these long-term outcomes that I'm going to talk about now. Next. So when we think about TTP and remission, and you've talked a lot about this today, many years ago, a decade or two ago, we used to consider TTP just an acute disorder with the expectation that you recover from TTP. And although there is a risk of relapse that's very scary, for the most part, people return to their previous level of health. However, as more patients survived acute TTP and were followed long-term, more long-term effects, particularly brain-type effects, were reported. And I have to give credit to the Oklahoma Registry and the support group that was started by Dr. Jim George, where they actually started to follow people and arrange support groups and talk to patients and ask them about their experience. And what they found was that patients were reporting subtle changes in their life that were problematic. And it wasn't just them. Their families also noticed that it was difficult for them to cope with certain parts of life. So that leads us to the neurologic sequelae of TTP. Well, what do they look like? There's really 4 types of things that we now know occur after TTP. The first is what's called neurocognitive sequelae. Next is neuropsychological, and this pertains more to mental health. And then vascular sequelae are related to the blood vessels. And finally, the impact on quality of life. And I will discuss each one of them in some detail. Next. So let's start with neurocognitive symptoms. What does this really mean? I do not mean frank dementia. I do not mean frank intellectual impairment. These are often more subtle than that and can be things like challenges with memory, remembering things, remembering a phone number, remembering where you kept your keys, the inability to focus on certain tasks, to carry out complex tasks. And many of the patients that we've seen are actually doing quite well in life, but when you ask more questions or when they get formal testing, they're able to identify that they're having more difficulty perhaps than they used to prior to their diagnosis. Next. And these are some of the things that patients have said to me, things like, I keep forgetting where I keep things or what I've already done. I make more mistakes than I used to, and that makes me very angry and upset. Or I'm in school trying to get my master's, but I just can't focus on my schoolwork. And a very common word that comes up in these clinic visits is it's like a brain fog, and I just can't do it. Next. And that brings us to the patterns of neurocognitive impairment. The challenge with these type of conditions is, to get a true handle on it, we need to test these formally. And when that was done, what was noticed was that these really are subtle deficits and not frank intellectual impairment or dementia. One of the earliest studies was also from the Oklahoma registry, where they evaluated 24 patients. They did not have dementia. They actually had a normal test called the mini mental state examination. They were independent in their normal work and daily activities and coping quite well. But they did have deficits in complex attention and sequencing, in manual dexterity, rapidly generating language, and rote memorization. And another study that was later done from the Ohio State University with Dr. Catalan that you just heard, as well as from University College Hospitals in London, they also found that patients had some impairment in tests of visual learning and memory. For example, this is if I gave you a list of 10 things, allowed you to look at it for 15 seconds and asked you to repeat it back to me. Those kinds of tests. Next. So the next question that comes in front of us as TTP doctors and researchers, but also for you, is like, well, why? What could be causing these problems? And some of the observations from these studies might help there. So in the Oklahoma study, what the authors actually noticed was that the deficits we're seeing here, these problems, are very similar to other diseases when people have tiny blood clots. Well, perhaps this is just residual from the acute TTP episode, whether it's one or more than one. Also from the Ohio State and London study, patients, when they had brain MRIs, they had small vessel changes. So like tiny blood clots that may have been new or old. And the big question before us, and something that many of you have brought forth in the panel discussion, is, well, are these changes just because of what happened during acute TTP? Or is this something that is continuing to occur during remission? And that's certainly possible, and that would mean that there's something that we should try to do about it during remission. And finally, there may be an association with other conditions, like are people with TTP experiencing more depression, because that does lead to subtle impairments in cognitive activity. Next. So the next part I'm going to talk about is neurovascular sequelae. Neuro means brain or neural tissue, and vascular just means the blood vessels. Now, why is this of interest in TTP? And that's fairly straightforward. TTP, at the end of the day, is a clotting disorder. And if blood clots form, they can deprive your brain of oxygen and lead to complications. So the same study from Ohio State and London, where they had evaluated people for cognition, they also did MRIs. And a really interesting finding was that in almost 40%, there was some evidence of ischemic or lack of blood supply or clotting injury in the brain. But this was occurring in people who did not have symptoms and apparently did not have any cognitive problems either, at least in general speech and talking with them, not so much in formal testing. What we do know is that this thing called silent infarction, which means that when you look at the brain MRI, it looks like a mini stroke happened, but there's actually no symptoms of it, can actually be a risk factor for stroke in the future. So that made us and many other researchers start looking at, well, is there an increased risk of stroke in TTP? Because that's something we need to know. And on following TTP survivors for several years, what was noticed was that for patients in remission, the risk of stroke was unfortunately fairly higher than that of the reference population, which means like if we took a control population, which was just like our TTP group, in terms of how old they are, what their ethnicity is, male or female, and compared them. And this was 13% versus about 2.5%. And that's concerning to people that take care of patients with TTP and for patients with TTP. But the next question is, well, why is this happening? And it is not completely straightforward because it doesn't have to be TTP. What we do know is that people that do have TTP also have a high rate of other conditions such as high blood pressure, potentially disorders like lupus, and those can independently increase their stroke risk. Some of them have already had a stroke or a mini stroke during the acute TTP, and that itself increases your risk of stroke in the future. And now the third one, and perhaps the most interesting here, is that perhaps ADAMTS13 activity and remission plays a role. So now this little cartoon here shows you people in red and people in blue. The people in blue are the people that completely normalize their ADAMTS13 activity after recovering from acute TTP. And that means their activity is greater than 70%. I'm not talking about now the greater than 20% that we like to see to prevent relapse, but truly normal ranges. And a little over half of the individuals did not get all the way back to normal. An interesting observation there was that most of the stroke tended to happen in the people that still had some low ADAMTS13 activity. And what that tells us is that perhaps this is an opportunity to study this more, but also develop an intervention to prevent this. Right, next. And that really brings me to the opportunities that we have as a field for screening and early intervention to prevent these outcomes. So I'd like you to look at this pyramid here, and this is really how we think about risk in terms of blood vessels in the brain, or stroke risk. At the bottom, you've got a population of people who may be at increased risk for cerebrovascular disease or neurovascular disease. This could be because they have diabetes, hypertension, and those kinds of disorders. It could be because they have a family history of early strokes and heart attacks, or it could be because they've had TTP. And now it turns out that if we start evaluating people, there is a group of people in this yellow block here in the middle that have some findings of mini strokes on their brain MRIs, but really have no symptoms in their daily life. They may show some findings if you do really detailed cognitive testing. And then a smaller group that goes on to develop stroke. And it is possible that this is a spectrum. So if you're at risk, the risk for silent infarction may be higher, and that might put you at risk for stroke. We already know that about 40% of TTP patients have shown these silent infarctions. So we have the opportunity potentially to study and to try to develop treatments to prevent these bad outcomes before people get to the stroke point, at the at-risk and silent infarction point, and that's the goal. There is research ongoing here, and hopefully by next year or the year after that, we can tell you more about this. Next. So the next aspect I wanted to touch upon is the neuropsychological effects, and that really means mental health. Sure, my patient has recovered from TTP, they're not having a relapse, but how are they really doing? Are they just surviving, or are they truly thriving? And this is where we start to worry about things like, the anxiety related to relapse risk, the psychological impact of having to cope with this completely unexpected and life-changing illness, and things like depression. Next. And this is something that has been studied. So again, from the Oklahoma registry, when 61 patients were screened for depression, over half of them had a positive screening test on a standard questionnaire. In another study that was done over the US and Canada with over 200 patients, 80% had a positive screen for depression. I'm going to temper that finding for a moment by saying that we asked people to participate, so it's very likely that people that were having more problems were more likely to respond. So the true number is probably lower than that. But interestingly, about 30% of patients also had a positive screening test for post-traumatic stress disorder. And we usually think of post-traumatic stress in the setting of wars and major trauma. But if we take a step back, and if I were to put myself in the shoes of someone with TTP, that's a pretty major trauma. It comes out of nowhere, and it's a serious illness. And it could be hard to cope from that. And patients that did have depression and PTSD did report that they were less able to go back to work, and they attributed that to TTP. So for us, that tells us that this is a very real social consequence of having TTP. And this remains an area that we are interested in and continue to do researching. Next. Now, Dr. Deep Terrell, that you'll have a chance to speak with during one of the breakout sessions, has done this research. And well, what do the patients say about depression and how to treat it? And some of the conclusions from their study, where they really just talked to a lot of people with TTP, were that, well, patients do believe that TTP is life-altering, but felt that counseling did help their symptoms and quality of life. In terms of medications to treat things like depression, the results were more skewed. Some patients that were on treatment believed that it was helping them, but others were not so sure about the effects. Next. Next. And these are some of the, sorry, back, Claire. These are some of the things that patients had told her in the study. The first one is about counseling, where this person felt that they really got their life back with counseling. second one is about a patient who feels that their life has been a lot better emotionally since they started on medication, telling us that maybe this is not something we can do nothing about, that things like counseling and medications help. But the third patient here really did not like the medication they were on and had significant side effects and felt like a zombie, which points out to us that we still need to do more work to figure out what's the best approach for which patient. Next. And finally, I'm going to talk about quality of life after recovering from TTP. So when we talk about quality of life, it's a really simple term, right? What's the quality of your life? But it really covers a lot of aspects, from how you're functioning physically right here in red, to just how is your general health overall, how are you doing mentally, often spirituality is also wrapped into that, and how you're able to function in the social sphere with your family, friends, and colleagues, things like pain, and finally, limitations to your activities, either at work, home, or in other aspects related to your health. And when this was looked at in the Oklahoma registry, patients with TTP did have some reduced quality of life on a standard questionnaire called the SF36 that we use partly because it's been used a lot and validated well, but also because it covers all of these aspects and it might help understand what's really going on here. Next. Now I'm going to show you these pictures, which are from a smaller study that was recently done by a student who worked with me, and she has been spectacular. But she also wanted to look at the relationship between quality of life and depression. And she used the same survey, the SF36. And let's focus on the left-hand side figure right now. And I'm going to walk you through this here. So this red line that you're seeing that's horizontal is at a number of 50. And that is the standard number that we expect the average of the population to be. Each one of these blocks is a different aspect of quality of life. Until you get to the last two, the brown one is overall physical components, and the blue one, is overall mental components. And now the line in the middle of these blocks is the 50% of the TTP patients. And what you're seeing here is that at least half of the patients with TTP, represented by these lines in every box, came below the average for the population. So they did have impairments in their quality of life. What was interesting to me was that a lot of these were more severe in the physical components, as can be seen in the last two, where the physical component score is actually lower than the mental component score. And when she divided this up by patients who appeared to have depression or did not by a standard questionnaire, the quality of life was significantly lower in patients who did have depression, in both the physical as well as mental components, which suggests that there's an association between the two, but also could treating or at least acknowledging the presence of depression help with quality of life in our patients. Next. So finally, let's get to future directions. Where do we go from here? Next. The first thing for us as a field is to acknowledge that we have a problem. You know, a lot of research in the last 5 to 10 years has told us that patients with TTP have varying experiences, and some of them may not go back to the previous level of functioning. And it behooves us as doctors to validate our patients' experiences and listen to them and try to figure out how we can help. As of now, unfortunately, there are more questions than answers. We don't really know what is the best way to prevent or treat these issues, but for what's available, we should try to provide. For example, if we do a depression screen and someone really does seem to have depression that is not being managed well just by us, perhaps we need to refer them for therapy or further treatment. And finally, and perhaps most important, is to conduct research to understand the risk factors for the neurologic problems, but also identify ways in which we can optimize these outcomes and optimize quality of life after TTP. Next. So these are the major issues in the brain area for TTP. We still need to really figure out how the cognitive problems, depression, and quality of life are related. Most interestingly, well, what leads to these neurologic sequelae? Is it acute TTP? Is it events that occur during remission, such as low ADAMTS13 or other things? And is it other factors that might go along with TTP, like other disorders? And finally, how do we prevent these consequences? Next. Dr. Mazepa has already mentioned that there is some ongoing research on this, and this is one of the studies on which he's the primary investigator, but is being done through the USTMA consortium. It's a pilot study of neurocognitive dysfunction for patients with TTP during remission. And the goal of this is to understand how common thinking and emotional problems occur in TTP, how many people have them, and whether they change over time. And patients are going to be enrolled at multiple USTMA sites, although it's currently open only at a couple of sites. And it involves every 3 months blood samples and a series of questionnaires about mental and emotional health. This is a pilot study, so that means that it is a smaller study that's going to provide information about a larger study to be done in the future. And finally, this is funded by a grant from the Answering TTP Foundation. Next. Another study that's open, although only at Johns Hopkins, is a study in which we are studying these latest neurologic outcomes after TTP. And the major questions we're trying to answer are: first, is silent stroke a risk factor for future stroke and cognitive impairment? And does low IRMTS-13 in remission increase the risk for silent or full-blown stroke? The goal eventually is to understand the risk factors for these problems and identify a treatment that we could use to prevent them. And what this involves is once a year, a brain MRI, some cognitive testing, and blood tests for at least 2 years. This is unlikely to be open at all USTMA sites, but if you are local, which means in the DMV area or even Delaware, and are interested, please feel free to contact me. Next. And now I'm going to open up to questions that we can take during the panel discussion. That's my email at the end if someone needs to contact me.
All right, I'm going to go ahead and promote the panelists now. There we are. All right, and if we want to start, just like Spiro did with his session, and have everybody introduce themselves and say where you're from, I think that would be good.
I can start. My name is Chris Gwynn. I am a clinical neuropsychologist at the Ohio State Wexner Medical Center.
I'm Dr. Mazeppa, back again for more questions here from the University of Minnesota.
Dr. Shruti Chaturvedi, and you just heard from me.
And I don't know if Dr. Lyles can get her camera on. Let's see. But in the meantime, we have plenty of questions here. Let's see here. One of the first one is headaches. So this patient is experiencing a lot of headaches. Could the increase in pain from the headaches be caused by TTP? So I don't know who wants to answer that.
I can start with that. I'm going to start with a caution that there are many causes of headaches, and if it is a sinus headache, then it should be treated as such. However, TTP is associated with a higher incidence of headaches, going forward, as was shown by some research by Dr. Catalang at Ohio State. I think we still need to know more about this particular situation, but it is, I don't think TTP would make sinus headaches worse, but could lead to more headaches in the future.
Okay.
I'd have to agree. I do notice that patients report more headaches once they've had a diagnosis of TTP, but what we try to do is see if the headaches fit a pattern of treatment, such as migraine or tension headaches, things like that, so that that might help us guide treatment. But I don't think at this point there's any specific treatment that we use for all our TTP patients, say treatment specifically for TTP headaches. And I think like so many of these questions today, it's we can we can assure you that we do see this, but it's hard to know if there's any specific treatment to offer yet. But we're working on it.
Yes, and I will add that at least some of my patients have seen benefit from being referred to a headache specialist who can try to tease out these patterns and identify what the best options might be for them going forward.
For this one patient, they've been in remission for 8 years and they're still having chronic fatigue and pain. Do you have any suggestions for them, or what route would you take? Would you suggest for them to take to help alleviate or mediate some of that?
So I'm going to start with saying that this is real. You know, I unfortunately don't have a magic pill for, but at the very least, we can acknowledge that this is a real problem and you're not alone. There are many, many patients with TTP who report these types of issues after recovery. What to do about this has been more of a challenge, and while we're trying to understand this better, what's likely is that we will not find a one-size-fits-all approach. What I've done in my clinic, and I will wait to see what my colleagues have also done, is try to evaluate my patients and find out if there's one or two things that might be contributing more to it, whether it's disorders in sleep, perhaps another autoimmune condition that has showed up, or are we truly just dealing with more chronic fatigue and pain issues? Some people have benefited from lifestyle changes, particularly, you know, gentle exercise that's been added onto their regimen. But overall, this remains quite challenging. And I cannot claim to have had great success with these situations. We're trying to understand better to develop treatments.
Yeah, and I'll echo that. I think fatigue is a challenging symptom for doctors because there are such a huge variety of different causes, and so many patients, even without TTP, sort of have this long journey of trying to make a diagnosis. So of course, just like any problem, we have to try to figure out if there's anything else contributing to it, if there's a new disease causing it, to try to make a difference. But it is a real challenge. So it's not something that's solved simply, but takes some persistence and work from both the patient and their doctor to try to figure out a way to improve the quality of life.
All right. So this patient is specifically a congenital patient, and they get extremely bad headaches 24 hours to 72 hours after a fresh frozen plasma infusion. Any thoughts on why that may occur? Shruti, you want to answer?
Sure. So one of the, perhaps the most plausible explanations is that this may be someone who is predisposed to headache-type reactions after plasma. And I wonder if modifying the pre-medications might help with this, whether it is what drugs like Benadryl or Tylenol or in different doses. We see this frequently with immunoglobulin infusions, but it's not impossible to get with plasma if it's only headache. If there are other symptoms, then they need to be evaluated more.
This patient wants to know, how would you recommend talking to PCPs or primary care physicians about the brain issues when you no longer are following with a hematologist?
So I think that's challenging because, I think the first thing one can do is talk to your primary care physician. If you're comfortable, you can take some of this information back to them. A lot of this is already published, and, speaking for myself, I'm happy to make some of this available to you because I think awareness is the first step. If your primary care doctors are informed, they may find it easier to engage with you on these topics. Failing that, perhaps seeing a hematologist with expertise in TTP might be helpful.
I agree. And you had mentioned before seeing a headache specialist, because again, even a hematologist is going to be somewhat limited in terms of our headache treatment sphere, just like a primary care doctor. So sometimes trying to find a headache specialist, whether you're being managed by a primary doctor or a specialist, a hematologist, I think is probably a good strategy. Some primary doctors are really comfortable at managing some headache diseases like migraine or tension headaches. So there's going to be some variability in primary doctors' willingness to take on headaches. But again, there isn't any specific treatment for TTP related headaches. What we try to do is see if these headaches fit a pattern of a headache syndrome. So again, that's still going to be the strategy, whether you're primarily followed by a primary doctor or a hematologist.
And if some of these issues pertain to the, cognitive impairments that you think you might have, or brain fog kind of feeling, there is no harm in asking if you could be referred to a neuropsychologist for evaluation. This is not available everywhere, but if it is, it might be helpful.
Okay. So if somebody is experiencing chronic migraines or frequent headaches, there are specialists who could look into that for them, who may be better suited to be able to tell them how to manage those. Is that the overall takeaway? Okay, cool, because we had a lot of questions about that. The next one is about imaging and how often you would repeat it. So the first patient, has had a lot of migraines, but they never had any sort of imaging done. Would you recommend they get imaging to be aware if there are any markings on there? And if there are any findings on their imaging, how often would you suggest they repeat the imaging?
Would you like me to, or Marshall, do you want to? I can.
Oh, well, I can start at least to say is that it's not very common actually that we do MRI scans in TTP. We know that we will see small areas of injury because of the causes of the disease. So typically MRIs are done in patients for whom we can't explain new symptoms or worsening symptoms. So it's a minority of patients that get these scans at the time of diagnosis. Right now, there isn't any recommendation for repeating brain scans as part of clinical care. So anytime we do a test as part of taking care of patients, we have to ask the question if we're going to do this test, whether it's a cheap test or an expensive test like a brain MRI, what are we going to do with that information? And I think that's probably why you haven't had repeated tests done, is that right now we don't really know what to do with that information yet. And it's still really considered an area of research. So I wouldn't necessarily recommend any specific time frame or frequency of scans. Generally in clinical practice, for new neurologic symptoms, we would do a scan to try to find the cause. So really, I think at this point, without new symptoms, it would be hard pressed to recommend a scan. But obviously I suspect based on the work done there at Hopkins that this may change over the next several years as we start to understand this disease during its, what we now consider to be remission. But I think while we traditionally think of remission and relapse as black and white, I think there's a lot of gray here in terms of when the disease is active. So right now, the answer is we don't recommend any routine screening tests of imaging the brain because we don't have any action to take based on that. But again, that may change as we start to learn more.
And our next set of questions are actually for Chris. The first one is, what is a neuropsychologist? And the second one is, how can they help a TTP patient?
That's a great question.
Yeah, that's actually a very great question. So a neuropsychologist is, we are in essence clinical psychologists with additional training, specialized training in brain-based behavior relationships. So what we do is we perform neuropsychological evaluations, assessing different cognitive domains, things like attention, concentration, processing speed, your ability to learn and retain information, as well as your higher order thinking abilities. And so I've notice one of the questions asked about the ability to work and integrate information and make decisions. And so a neuropsychological evaluation will assess all those cognitive domains, as well as someone's emotional functioning as it pertains to their cognitive functioning. And so the evaluation can take up to 4 hours to evaluate all these kind of domains. So how we can help in this process, as well as in other medical diseases, to examine changes in thinking abilities as it relates to certain medical conditions, as well as weaknesses within the person's performance, to make recommendations to target those specific weaknesses. So someone may have problems with memory, and so that's what they come into our office complaining about problems with memory at work. And so through the course of the evaluation, we may find that it may not be a problem with memory, but it's really problems with attention and concentration. So if you are not attentive to your surrounding, you can't retain information. So it's not a memory issue, but it's an attentional functioning issue. And so broadly, the attentional issue may be related to your anxiety, to your depression, to post-traumatic stress disorder from certain medical diseases. And so we parcel out what is contributing to these cognitive deficits that patients are describing and make those recommendations. So some of the question that has been posed now is, why can't I do my job? And so what I do in the clinic is to figure out, is it a cognitive issue? Is it an emotional issue? Is it a fatigue issue? Is it poor sleep? Is it headaches? Is it chronic pains? And we can tailor the recommendations for care.
That's a great description, Chris.
Yeah.
And I think this is a disease that's traditionally treated by hematologists, and it sort of fell into our realm because we see changes in the blood. But what you can tell is that the disease affects many parts of the body. It's an immune disease, it's a blood disease, it's a brain disease, it's a kidney disease. And so I think our job as hematologists, I think over the next several years, was to trying to build our treatment team a bit broader than just hematology. We want to try to bring in experts in disorders of the brain and blood vessels and other organs, and try to build that team of experts more broadly. Again, we've already mentioned headache specialists, those sorts of things. So I think we'll start to see over the next several years a broader approach to the disease to try to help people as we learn more about how the disease affects people beyond just the blood, which is our area of expertise. But I think we've recognized that it's not just a blood disease, and we need help from other experts as well.
Okay, so here's a popular question. This patient had a TIA with no residual effects, but they want to be able to prevent any future incidents of ischemic events. Would that be best just to manage their TTP, or how would they best prevent future events? And if they do go in to an acute episode, how do they protect their brain?
That's a really important question here. What we do know about mini strokes or TIAs are that whether you have TTP or not, having one of these puts you at risk for stroke that's higher than the risk of someone who's never had a TIA. TTP perhaps increases that risk a little bit more. Now, as of today, we don't have one treatment to give that's going to prevent a future stroke, although preventing relapse is probably going to help, because having a TTP episode is a huge risk factor for having a stroke during that episode. For patients that are in remission, there is still the worry and the risk of what if I had a stroke or another mini stroke or TIA while in remission? And What we've done for that so far is to do everything else that we can do to reduce the risk of stroke. And I will often collaborate with one of the neurologists that works with my team to do that. And that might take the form of medications such as an aspirin or a Plavix. It might take the form of medications that control your cholesterol, so that we take care of everything else that could increase that risk. And then we're left with the TTP specific risks, and we do what we can to prevent a relapse. And hopefully in the next couple of years, we'll understand the relationship of ADAMTS13 with stroke risk better, and that'll provide us guidance on how to approach that. But right now, it's fix everything else and try to prevent TTP relapses.
Absolutely, yeah. I think what's one of the tricky things about this disease that we've all touched upon is that it seems like ADAMTS13 deficiency is necessary to cause disease. We don't know how much deficiency is necessary, especially for TIA or stroke. But then there seem to be other factors because some patients do fine with low levels of the enzyme and others don't. And so it does make sense to treat other components of what could cause a TIA or stroke. So most people are familiar with these common risk factors for stroke and heart attack, like high cholesterol and smoking and diabetes, high blood pressure. So those are those classical, what we call cardiovascular risk factors. So these are things that we think damage blood vessels over time. So again, damaged blood vessels plus sticky blood proteins could cause clots. We try to treat both of those.
Here are two good questions for Chris, actually. The first is a patient who's dealing with memory issues, mood swings, lack of patience, inability to focus on work, and they're making mistakes that they feel like are stupid at their job. What are some things that you might suggest, or that you might suggest the patient have evaluated that might help them cope better with the cognitive impairment they're experiencing? And then I'll ask the second question after you answer the first. How about that?
So I think the first important thing is it's important to be open and honest with your doctors. And so what you should do is to report all these symptoms, of course, to your primary care doctor or your hematologist. And the next thing that he or she would do is to refer you to a neuropsychologist or, if appropriate, to a psychologist to better evaluate some of these symptoms, to see if it would warrant a diagnosis of depression, a diagnosis of anxiety, or a diagnosis of PTSD. Because each of those disorders would warrant different treatments. So that would be my suggestion, is to be open and honest and be clear with your doctors, your treating provider, and they would be able to better assist you with looking at referrals in their institution and get you the appropriate care.
And if it's determined it's something like a fatigue issue, what are some things, or what are some possible treatments that are out there, maybe not specifically for this patient, but just in general, to make people aware of ways that that's being handled?
For the fatigue, I'll let the physicians answer that. But as far as like a behavioral health component, for most patients I see with chronic pain, chronic fatigue, is that they are still active and they're still working, and they're still doing house chores, taking kids to sports on the weekends. So the normal everyday routine. And so what happens is these patients have medical conditions that cause fatigue, but they're still being very active in what they do. So the implications for that is it takes a day or two to recuperate, because they're tired. So there are treatment for that in terms of behavior modification treatment in how to better plan, better manage your day-to-day routines, so you don't get to a point where at the end of the day you're just so physically exhausted, and then you spend the next 2 days recuperating from that. And so behavioral health, that in a sense, it's a behavior. You're doing it because it's a behavior, you're active, and that's how you've always been. So in seeing a behavioral health psychologist, the idea is to change that behavior and do it incrementally, so that you're not expending all those energy.
Okay. And then the next question that was brought up is there's a patient who already has a neurologist and the headaches are actually being well managed with medication, but the cognitive impairments are getting harder to hide and deal with. Would you recommend that they speak to a neuropsychologist about that? And what's the best way to tell their physician that they would like to talk to a neuropsychologist?
So it depends on the institution you're at. At our institution, a neuropsychological evaluation has to be ordered from a physician. And so the best way to do that is just to tell the doctors, I'm having these cognitive issues, and it's impacting my day-to-day functioning. So I am requesting an evaluation. So that is perhaps the most efficient way of requesting an evaluation. There are other clinics that are that you can request this evaluation without physicians. But the best way that I would recommend is just ask your provider to refer you to specialists, to neuropsychologists, and that's probably the most efficient way to do this.
Okay. Would you believe that a neuropsychologist would be able to benefit a 3-year-old with congenital TTP that has shown different neurological signs? Or is there a point where age becomes a factor and it may not benefit the pediatric patients as much?
I'm biased, so I'm going to say it will always benefit. But yes, we do have specialties in pediatrics. There are pediatric neuropsychologists that would be able to assess a 3-year-old. And that's important because we want to see if that's related to TTP, related to a learning disability, or something else that we need to dedicate more clinical attention to. And so yes, that 3-year-old would benefit from a neuropsychological evaluation. And so yes, there are pediatric services that could be able to evaluate a child.
Perfect. Here is a question. This patient was diagnosed with peripheral neuropathy a few weeks after entering a TTP remission. And could TTP have caused the neuropathy, or was it likely a side effect of the treatments like the steroids or antibiotics that the patient was on? So I don't know if Shruti or Marshall wants to take this one.
I would say peripheral neuropathy isn't a common finding in TTP. It's a disease of the nerves, so it certainly could be. You know, peripheral neuropathy is quite common, and it's worthwhile, or it's probably one of the most common reasons that patients of all types would see a neurologist to find for an evaluation of potential causes. I think one of the challenges of attributing this to medicines is there isn't, say, a test we can use to prove that, say, a certain antibiotic caused it. In terms of causes, the most common cause is diabetes. Now, sometimes people develop diabetes temporarily from the steroids, but we're really talking long-term. You know, over the course of many years, diabetes can cause peripheral neuropathy. Certain drugs are known to cause damage to the nerves and cause peripheral neuropathy. So a neurologist can help you sort through what are the potential causes, which is important because if we can find a cause, then sometimes we can prevent further progression of those symptoms. On the other hand, probably the most common reason for neuropathy is that it's unexplained. But again, a neurologist can help you understand what are the potential causes of peripheral neuropathy. I wouldn't say it's impossible to be caused by TTP, but isn't among the more common symptoms we see from it. So I think given that, it's worthwhile to try to find other treatable causes. And then there are medicines that can be used to at least treat the symptoms from this.
I'd echo what Marshall says. It's less likely to be TTP, and the patient deserves an evaluation to see if there's something we can correct.
And this will be the last question for the session before we break for lunch. This patient had a TIA on the brain, a blood clot rupture in their eardrum, and a blood clot that made them lose vision. Thankfully, it was only for 3 hours. They have cardiac issues and joint pain. What would you recommend to help these issues be prevented in the future, and how to feel better now? They have severe fatigue. So it sounds like it would be a good open communication with the physician and a few other things you guys have suggested, but go ahead.
No, that's exactly right, Claire. Things that we talked about before is that if someone's already had a TIA or stroke, we must do our best to address all of the underlying causes. So it was like a blood clot or a ruptured blood vessel that led to these problems, then certainly managing blood pressure is critical. You may benefit from medications such as aspirin or cholesterol lowering medications that should be a discussion with your doctor. And on the other side, we do everything we can to prevent TTP relapse. But lifestyle modification and modifying all of the other stroke risk factors that we can would be critical to trying to prevent this from happening again.
Yeah, and I think Dr. Catalan has mentioned, that the strategy for trying to prevent relapse is really tailored to the patient. Mm-hmm. And so in people who've had really bad TTP episodes, I think our bias tends to be more aggressive in trying to use medicines to suppress a future relapse, because the potential benefit is higher in that patient who might have more serious complications as a result of having a really bad first episode. So there again, our approach is we try to think about what are the risks and benefits of using medicines to push down on the immune system. And I think this is a person who, given the severe first episode, we might be on the more aggressive side. But again, that's more of a style and a careful discussion with your doctor about what are the risks of being more aggressive compared to the benefits to you.
All right, and with that, we will break with lunch. Anyone who didn't have your question answered, don't worry. Again, I'll be trying to work them into other sessions. And there's the Ask the Hematologist breakout session, where we'll be doing just a potluck of different question and answers for the Board of Physicians there. In addition to that, feel free to reach out to us at any time. The email address is admin, so ADMIN, at USTMAconsortium.com. We're happy to respond and get some questions answered, do all that we can through email. But we will be returning at 12:50 p.m. Eastern time. And we hope you guys will join us back then. Thank you so much for everybody who joined us on the panel, and we'll see you at 12:50.
Thank you.